I just thought I'd revisit some pretty basic stuff, but the common things that we might all see, and the things that you might see that we probably don't need to see as specialists is the reality. So we'll start with this, and I'm hoping for a bit of audience participation. So we've got a 7-year-old with a fall a few days ago, presents late, ongoing pain. Just shout out, what do you see? What's the most obvious feature? It's a type of green stick fracture. This is specifically a torus type fracture, not a green stick fracture where there's no displacement, but a torus where it's actually creased. What would be the standard management in your practice if you see these? Does anyone know? No? Yeah, so often these kids are actually coming through for a cast of variable duration, but the evidence is pretty thin. So there's a very keen paediatric orthopaedic surgeon in Oxford called Daniel Perry looking at all of these distal radial type fractures, and he's done a meta-analysis of the literature, and overall it's very poor quality evidence. The NICE guidelines are actually quite indicative of this, and the actual recommendation is just a splint for a few weeks. The pain usually subsides after about 3 weeks, and these are inherently... Apologies. And the actual pain usually subsides, and then they're actually pretty stable. They can usually return to sport at about 6 weeks, independent of their age. So again, these are probably over-treated. They don't need a full cast. They could have a soft cast or just a splint from actually over the chemist or from a hand therapist, one of the rigid splints. What about this one? We've got a 7-year-old who's fallen off his bike. Everyone's saying, ooh, yeah, it looks nasty, doesn't it? So, off-ended distal radius and ulnar fracture. Do you know what the current treatment for these are? Anyone? They usually come to theatre, and very keen registrars give them a big pull and then try and relocate both the radius and then relocate the ulnar, and then they get wired if they're unstable. And this is actually quite interesting because there's one of the most common type fractures. Wires left out to be pulled in clinic are not innocuous. If they're left out for longer than 4 weeks, they can actually cause infection.
Sorry, I know that you guys can hear her, but I'm trying to adjust this for the webinar people.
They can actually cause quite a bit of infection. So historically, we know that these used to heal, and the remodelling in under 10-year-olds is fantastic. The actual children guidelines say if they're bayoneted, so if they're actually on the end but not overlapped, or if they're overlapped only 1 centimetre but they're overall aligned, we could probably leave these. But that creates quite a bit of consternation amongst the parents because everyone wants it to look normal and they're worried about the healing. So CRAFT is a randomised controlled trial that's been registered again through Oxford. Daniel Perry is doing this, looking at all of these different type of fractures. The North Americans had a small population cohort where they randomised 38 patients in each trial, but small numbers, and they actually showed successful outcomes in the short term and long term with actually just leaving them and without them having to actually go to theatre. So you can actually do a little reduction in ED where you're just aligning everything, and as long as it lines up, you can actually leave them overlapped because they'll heal beautifully, okay? So this is what the CRAFT trial is hoping to actually look at, is a higher number of volume of patients. So paediatrics is continuing to evolve, and what we're looking at is surgery with cast and or wiring versus non-operative, where they're still having a cast to actually maintain it. And by the way, this is a short arm cast, not an above elbow cast. And then they're actually going to follow them up for 3 years and look at the long-term outcomes. So an exciting space to actually be a part of. And what you can see here is over time, these do remodel, and these are the images we need to be showing to the parents to actually reassure them that actually it will be okay, and all their child needs is a good, well-moulded cast and maintained alignment, okay? What about another pretty common one, a 10-year-old who's rolled his ankle playing soccer? What are your thoughts on that? So the most notable feature is there's a significant amount of soft tissue swelling laterally. So is this a fracture or is this a ligamentous injury? Who votes for fracture? Put your hand up. 1, 2. Who votes for a ligamentous injury? Many more people, yeah. And this is actually quite, again, another interesting area. The traditional teaching is this is a Salter-Harris 1 or 2 fracture of the distal fibula. And usually if you palpate along the fibula, you'll find quite focal bony tenderness. The question is, has it involved any of the lateral ligamentous structures? So this is a weight-bearing X-ray. It shows you that the ankle is inherently stable. So it's not a significant disruption, and it actually just needs, again, appropriate treatment. So what do we know about treatment for either a first-time significant ligamentous injury or a fibular fracture? Well, this is again a systematic review looking at using PRISMA guidelines. They found over 30 articles, and what again they found is there's very low quality evidence, and these injuries are either undertreated or completely overtreated. The basic treatment for both is rigid immobilisation for 4 weeks, whether that's a boot or a weight-bearing cast. That's the most important thing for a significant lateral ankle injury, whether it's a fibula or whether it's a significant ligamentous injury like a grade 2, okay? And then the next most important step is you guys looking at rehab, because that's actually what gives them the best outcomes when we're looking at return to sports and avoiding chronic ankle instability. There was a recent article, look, this is adult Iranian soccer players, but again, the highest risk. And they did a very interesting physio trial where they randomised 36 patients, 12 in each arm, and they looked at standard proprioceptive training, then they did a hopping group, and then they did a balance and strength group. And the combination actually, hopping did a little bit better in a few things like vertical jump when you looked at 8 weeks of results, but the actual balance plus strength group did better with inversion injuries long term. So this is really the important component. It's proprioceptive, strength, and actual flexibility based, and they actually need to do really well before they get back to sport, especially soccer. The nature of any game where you're wearing spiked boots places a huge amount of shear across the ankle when they're running around. So it's great for foot-based stability during the game, but you've actually got to protect them for a period of time so that they don't become a chronic ankle instability patient. Okay. Oh, we'll go to clavicles. So this is a pretty standard one. 15-year-old male who had a tackle during sports. Is this a bad fracture? Anyone think? It's pretty angulated, isn't it? So it's angulated more than 30 degrees, which in some guidelines would suggest that they're at risk for malunion and repeat fractures. That's one of the worries, okay? And what about this one? An overlapped, shortened clavicle fracture. Does this one need fixing? No? Some people say no. Look, the reality is there's an increasing trend in the adolescent group for fixation, and there's no evidence to actually guide it. So that's where we actually have to inform our orthopaedic colleagues. There's a fabulous review that just came out recently looking exactly at this, and it's a retrospective review of several hundred patients turning up to the Royal Infirmary of Edinburgh. Out of all of them, only 7% went to fixation. And when you look, and this has been repeatedly found in the literature to try and answer this question, when you look at the non-union rate in adolescents, and that's at least until the age of 18, the non-union rate for displaced, comminuted or angulated fractures is actually 0.05%, and so it's very, very low. And so what we've seen is a trend where adult-type practices are now impacting paediatric or adolescent fractures, and there's quite a bit of perhaps more surgery than is necessarily indicated, because we know what the non-union risk factors are for adults, but that isn't the reality for children, okay? And that, again, just takes a lot of parent education and information. So these can actually be successfully managed in the community in a sling for 2 weeks, and then they actually can start, you see they actually start developing below shoulder range of motion, they're able to dress themselves, and if I see those patients, I just say wear a sling when they're out and about, just as a warning to other people that have had a recent injury, but at home, at school, they should be coming out and doing everything that they can, and return to sport is at about the 10-week mark. So those are the results for those 2 patients. So they actually all heal. The question is there a refracture rate with the angulation ones? And in some patients there are, but by far not in all patients, and those just need to be monitored, okay? That was a quick update. With regards elbows, there's a very good, I didn't include it because it's only just come out in the last week. There was a really good analysis that actually reviewed all fat pad signs, and if you see a patient with either an anterior or an anterior to posterior fat pad sign only with no identifiable fracture, you can be sure that 50% of them have a undisplaced fracture, okay? So just be a bit wary about elbows, because most of them are supracondylars and they will need a cast for about 3 to 4 weeks. And that's where a clinical assessment's actually very, very useful. You need to take them out of their initial immobilisation and examine them and find the bony tenderness. You don't actually need to continue to re-x-ray those patients, because if it's just a radial head or neck fracture that's undisplaced, then they only need a cast for about 2 weeks, or even just a sling, and they will be absolutely fine. So you just want to make sure that through a good clinical assessment that you're diagnosing the nature of the injury and that you can prognosticate for the family. That was the mainstay of the treatment. Just an update on PEDS fractures and the fact that we're evaluating things ongoing. Thank you.